talk in the Parkinson Disease Foundation's 7th series of expert briefings. It's entitled Apathy or Depression, Which One Is It? And I'm thrilled to say we have what seems to be another record of people signed up, a total of almost 1,600 people signed up for the session, and most of whom are on the call already. I'm also particularly interested just sort of watching this series and see how it fits in with our mission overall, that we have an increasingly large numbers of healthcare professionals in these meetings. More than 250 social workers, 150 nurses, in addition, of course, to a very healthy number of lay people who live with Parkinson's, or live with the people who do. And so it's a great audience, and we're just thrilled to be able to welcome you all to this one today. As in previous encounters of this kind, we are joining as co-sponsors with a group of independent regional organizations that we call the Alliance of Independent Regional Parkinson's Organizations in diverse places, major cities around the country. We're thrilled to have them be co-sponsors with us. And of course, we depend, as always, and want publicly to announce and thank the two great companies who make the series possible. One is AbbVie Incorporated, and one is Lundbeck LLC. We obviously couldn't do this without their support. We're very, very grateful to them for all they do. As we remind our participants in each session, our companies are essential to the financial support of this series, but in no way do they involve themselves in the design of the series, selection of topics, or anything else. It's done as a public service, and we greatly appreciate that too. To those of you participating, I want to remind you that the PowerPoint slide deck can be downloaded from the reminder email you should have received this morning, or, if you prefer, from the PDF webpage that highlights this talk. So those of you who are old hands will have no difficulty with this. Those who aren't, please either download from the reminder email or look at the PDF webpage that highlights the talk. I should remind you that if you are one of the many health professionals, you can earn one free continuing education unit through the American Society on Aging. If you registered as a health professional and indicated that you would like CEUs, you'll receive an email by the end of today with steps on how you can collect it later. You have then you have 30 days until July 14th to collect the CEU to which you're entitled. So please take advantage of that if you wish. It's now my great pleasure to introduce our guest speaker for the day, Dr. Dawn Bowers. She's a PhD professor of clinical and health psychology and neurology at the University of Florida and director of the Cognitive Neuroscience Laboratory at McKnight Brain Institute. I've just learned in the last few minutes in chatting before the talk that she's a close colleague of Dr. Michael Oken, a very well-known clinician and scientist in the field of Parkinson's, and Dr. Oken in his role at the university, but also his role at the National Parkinson Foundation. I'm very happy to say, on behalf of the PDF, which I represent, they're to be partners of ours in a forthcoming merger over the next few months. And so we'll be even closer as a colleague with Dr. Oken, and I certainly hope Dr. Bowers as his respected colleague at the University of Florida in our future endeavors. This is a very fine enterprise, and we're witnessing at PDF a very fine example of that in Dr. Bowers' presence today and her talk. So I wanted to spend a second more on her resume. I'm going to give you a summary. It's a very rich one. She has neuropsychology, as we talked about. Her specialty is in memory disorders and emotion processing changes in Parkinson's disease. She's received numerous NIH grants, and these have resulted, along with other support that she's received over the years, in a total of 175 peer-reviewed research articles and presentations. She also co-authored books on helping people with memory disorders. She received both her doctorate and her master's in clinical psychology from the University of Florida, and she has completed also a postdoctoral fellowship in behavioral neurology, also at the university. So we're thrilled to have her, continuing our rich and long tradition of only getting the very best people to give talks in these enormously important areas, and certainly Dr. Bowers continues that tradition. It's my delight and pleasure to introduce to you now Dr. Bowers. She will speak for, I think, it's a half hour or 40 minutes, and after that you can then be asking your questions. The lines will be open to Eli Pollard and Valerie Holt and our colleagues here at the PDF, so feel free to email your questions as she speaks, and then we'll be selecting and organizing at least some of those to have her answer in the remaining minutes. So we'll look forward to hearing from you as things go along. Dr. Bowers, delighted to have you, and the floor is yours.
Well, thank you all for logging in to hear this webinar. I'm really just delighted to talk with you today about a topic that's really dear to my heart, apathy or depression. Which one is it? My name is Dawn Bowers. I'm a clinical neuropsychologist who studies emotional changes in Parkinson's disease, and I come to you from Gainesville, Florida. Okay, so let's talk about exactly where that is. It's a small university town located in north central Florida. You can see it here. It's marked by the red star on the map. We're about 100 miles north of Orlando. We're home to the University of Florida. It's at 50,000 students approximately, a land-grant university. It's a public university. It's home to famous Gatorade, which was invented by a university physician to help hydrate the football team. UF is also the home to the Center for Movement Disorders and Neurorestoration, which is directed by Dr. Michael Oken. And this is where I see patients, do research, and educate students and fellows. Sorry, I missed a slide, and I'm walking backwards. Okay. So our center is uniquely interdisciplinary, and I wanted to emphasize that. And it consists of neuropsychologists, psychiatrists, neurologists, speech therapists, physical therapists, occupational therapists, social workers, and nurses. And we're all in the same location, and patients can come to us and do one-stop shopping. I know it sounds like I'm doing a PR blurb, and I really am, because I wanted to emphasize how important it is to have interdisciplinary teams to work with patients with Parkinson's disease. Our center was established in 2002 by Dr. Oken and Dr. Foote, and we're really committed as clinicians and educators, and we're also researchers. I direct a grant which is focused on training new movement disorder researchers going forward. But first and foremost, I want to say that our mission and our motivations are you, our patients, our parents, and our children. So for today, our plan is to provide an overview of what we're going to be talking. I'm going to provide what we're going to be discussing. I'm going to begin with differences between apathy and depression, how they're diagnosed, tools that are used to measure apathy, and why distinguishing them can be a problem for some. We're going to talk about why apathy is such a problem, how it affects patients in their everyday life, how common it is, and what we think is its underlying cause. Then we're going to transition to what's known about treatment, both pharmacologic and other, the current state of the art. And finally, we'll end with some suggestions for clinicians and patients for how to tackle this really important apathy problem. So, as you know, emotional changes are common in Parkinson's disease, especially depression, apathy, and anxiety. Now, I want to be clear, just getting a diagnosis with a chronic illness like be it Parkinson's disease or cancer can prompt depression and anxiety. But in addition to this normal reaction to having, an illness like this, it turns out that Parkinson's disease does affect some of the brain circuits that are involved in emotion and motivation. And some of these are shown on this slide. I'm not going to go into detail, but to say these are all ones that are affected by dopamine loss. They include some of DeLong's basal ganglia loops. They include some others, the mesolimbic and mesocortical pathways that actually feed into the emotion circuits of the brain. Now, I want to mention that apathy is not just unique to Parkinson's disease. We see it frequently in other disorders, so it occurs in stroke, Alzheimer's disease, vascular dementia, and even mild cognitive impairment. So these disorders aren't necessarily characterized by dopamine loss like in Parkinson's disease, but they can affect the brain's motivation circuits. So until recently, apathy was viewed as a form of depression. But now we are beginning to view them as very distinct syndromes that have some overlapping features. We'll talk about this in more detail in some upcoming slides, but for now I want you to think about depression as being a mood disorder. So it's a primary mood disorder, whereas consider that apathy is a motivational disorder. Now the word apathy comes from the Greek. It means without passion. And motivation comes from the Latin, and it means to move. So think about, again, apathy, lack of passion is a disorder of activation and movement towards some goal. Now, I became interested in this about 10 or 12 years ago, largely because I was having a conversation with a woman who had Parkinson's disease. I had just developed this new tool for measuring facial movement, facial expressivity, and I got in a grant to study ways to improve the masked face in Parkinson's disease. And when I was talking with this woman with Parkinson's disease, she asked me, would this help the intense feelings of apathy she had begun to feel? And later on, I was talking with her privately, and she was adamant that she wasn't depressed, that this was something different, that she had lost her get up and go. This was fascinating. And what she described were some of these types of behaviors. She was describing having difficulty initiating activity. She was less interested in learning new things. It was hard. She didn't have as much effort directed towards being productive. She was still working, and she was just finding she was losing her interest in that. She needed people or needed her husband to help her do things, to remind her to do things, and she just really wanted to sit around and watch TV all day. And she did not view herself as being depressed at all. So what she described was interesting because it's really very similar to some of the emotional changes that Ken Heilman, who's a behavioral neurologist, talked about following strokes to one side of the brain, where these patients, particularly the right side, who tended to be flat and apathetic, they weren't depressed, yet strokes the other side of the brain resulted more in depression. So there was this dissociation, this difference between apathy and depression. And indeed, when I started digging deeper into the literature, I found that a really brilliant psychiatrist by the name of Robert Marin first described something called the syndrome of apathy. This was in 1991, and he also viewed apathy. He was the first to propose it, that it was a disorder of motivation, a failure to initiate goal-directed behavior. And he thought of apathy as consisting of playing out in three different domains: cognitive, where there was a loss of interest, decreased curiosity; emotion, where there was sort of a decrease, sort of emotional flattening, a decreased reactions to emotion; and behavior. And here, by that he meant reduced initiative and drive. And one of the important points that Marin made is that it's a primary defect. It's not due to dementia. It's not due to impaired taking drugs or anything like that. It was a primary disorder. So why is it important? Well, in many diseases, we find that apathy's been associated with undesirable things, can even result in negative consequences for people with Parkinson's disease and their family. So some of the things that have been associated with apathy, as it's been studied, are shown on this slide. Many family members that I've seen don't understand that, or view their person with Parkinson's disease as being lazy or stubborn, and they don't understand that what they have is this disorder, this inability to initiate or reduced ability to initiate it. And they don't appreciate this as part of the disease process. So they're just having a difficult time. And I want to show you this slide. This next slide. This was a study that was done by a graduate student who was visiting from the University of Maastricht. This was part of her master's thesis. And what she did is she looked at patients and how they spent their time over the course of the week. So she had a group of apathetic Parkinson's patients and a group of non-apathetic, and she called them multiple times daily, both them and their caretakers or their family members, and she clocked what they were doing. And what you can see is that the apathy group, which is in the dark bar, was watching television a lot. And what they weren't doing was being involved in their hobbies or being involved in gardening. So they spent a lot of time being more passive recipients. One of my colleagues glibly suggested that perhaps removing TV from the home might help, and I think not. But if someone's spending most of their time watching TV, this isn't really good for a lot of different reasons. What we're going to turn now to is how do we measure apathy? And there are a lot of different tools that have been developed over the years. This is just a sampling of the most frequently used ones that have been validated. I'm going to describe 3 of these briefly just so you know what's happening out there in the literature. And the first is the apathy scale. It's the most widely used self-report apathy scale in the literature. Some of the sample items are shown on this slide. So are you interested in learning new things? Does someone have to tell you what to do each day? Are you indifferent? So each item's rated on a scale from 0 to 3. It was actually modified from one that was originally developed by Bob Marin. It was shortened and the wording was made a little bit simpler. There are 3 versions, and they can be completed by a patient, a family member, or it has clinician ratings. The psychometric properties are pretty good, and I can look at each of the 3 components of apathy that Bob Marin talked about. Another scale is called the Lille Apathy Rating Scale, and this is a little bit different. It's actually a semi-structured interview that's carried out by a psychologist, or it could be carried out by a nurse or someone. And it has 33 different items. It has that sample 9 different domains that are shown in this slide, and they all feed into these composite scales, which really deal with intellectual curiosity or the cognitive component, emotion, and action initiation. This is a great scale. Unfortunately, it takes a lot longer than the apathy scale. Then finally, another item that's been used is the 4th item from the United Parkinson's Disease Rating Scale, and it's short. It's very quick. But it's not very sensitive and not very specific. But so in our work, we don't use it, but sometimes all that's available is the United Parkinson's Disease Rating Scale. So this could be used as a quick screen as possible if available. So, but our recommendation is using either the apathy scale or the LARS. The apathy scale is quick, short, and well suited for screening. We found that the LARS is more sensitive for detecting changes. So if you're doing a treatment study, then you might definitely want to give the LARS. So there's a trade-off. Now, I mentioned, I didn't mention, there's a lot of variability in how much apathy we see in Parkinson's disease across studies, and they have ranged from 12 to 70%. That's a big difference. So you might ask, how does that happen? Well, it really happens because all these different measures are used, and different measures are used, and apathy is assessed in different ways. Recently, there was a meta-analysis that was done, and it looked across used various criteria, and the authors looked across 23 different studies, and they found that apathy occurred, or clinical levels of apathy occurred at about 40%. So about 40% of the individuals in these studies, on average, had apathy, and apathy was associated with worse scores, worse motor scores, older age, and lower scores on a cognitive status exam, the MMSE. We might ask, how could there be so much variability? Like I said, it really relates because it's measured in different ways. Typically, one needs formal diagnostic criteria to make a diagnosis of apathy. And currently, psychiatry does not recognize apathy as a syndrome. And there are no diagnostic criteria in the DSM-5 for making a diagnosis. So people make estimates of prevalence based on scores on the tests, some of the tests I showed you. Because of this, at least two groups have put forth diagnostic criteria for apathy. These are all directly modeled on how Bob Marin originally thought, what he thought apathy was. And they emphasize, it's a motivational disorder with problems across three different domains. And these difficulties can't be accounted for these difficulties have to cause clinically significant distress and impair social and other areas of functioning. They can't be due to medications and reduced level of consciousness. Okay, so now let's turn to depression. Depression in Parkinson's disease plays out in a number of different ways. Many patients with Parkinson's disease have classic depressive disorders ranging from major depression to to low mood or dysthymia. Major depression can last from weeks to years. It can occur in any stage of the disease. Some patients, I'm following some patients now who've become depressed at the time of diagnosis. They're sort of coping with having this diagnosis of Parkinson's disease. Other patients become depressed as they are faced with more and more motor problems and more disabilities. So there are many reasons why depression can occur. So at the other end, from depressive disorders like major depression, there can be mood fluctuations, so the rapid shifts from low to high mood. And this occurs mostly in individuals who develop on-off motor fluctuations. And not everyone experiences this, but it is dramatic when it occurs. So when they're in the off state, they're feeling more dysphoric, and when they're on, they're feeling better. Perhaps more common also with mood fluctuations is anxiety, because this can all be very distressing. So how do we diagnose depression? Well, we do it in a number of different ways. We typically do a clinical interview following the major diagnostic criteria for major depression, and we want to check to see if a patient fits the diagnostic criteria, and I'll show you those in just a moment. There are a variety of different depression scales that can be completed by a patient, like the Beck Depression Inventory. There are scales that psychiatrists or psychologists can complete, like the Hamilton Rating Scale. So these are clinician rating depression scales. Now, to be really clear, these depression scales only inform you that a patient has lots of depression symptoms or not. It's not really proxy for going through all the criteria, so they need to be used in conjunction with one another. So there are lots of options. Now, to receive, though, a formal diagnosis of depression, there are 9 symptoms to consider. A patient has to have 5 of these on the list. And at least one symptom has to either be sad mood, which is the first one shown there, or diminished interest or pleasure. So these are called the cardinal symptoms. So one of these two or both must be present. In addition, they must have a total of 5. These symptoms have to be present for at least 2 weeks. Everyone can have ups and downs. Everyone does. But for a diagnosis of major depression, these symptoms have to be engulfing and affect normal functioning and well-being. So before we move to the next slide, I want you to take a look at some of these symptoms, numbers 3 through 9. Insomnia, slowness, fatigue, poor concentration, weight loss, and so on. Does this remind you of some of the symptoms we see in Parkinson's disease? Well, because of this, because some of these symptoms are ones that we see in Parkinson's disease, diagnosis of depression can be difficult. The features of Parkinson's disease itself can be confused with signs and symptoms of depression. So it can be tough. So consider how a patient with apathy might be confused with being depressed. A person with apathy could have decreased interest. It's one of those cardinal signs of depression. They could also be slow, fatigued, or have insomnia, difficulty concentration due to well-known symptoms of Parkinson's disease. And in that case, a patient with apathy could be misdiagnosed as being depressed, when in fact they're not. And the next slide we're sort of going to skip over, but it just shows you how signs and symptoms, the column going down through the middle, could be interpreted as being due to a Parkinson's disease symptom on the left, or it could be due to depression, anxiety on the right. So think about looking sad. That could be because a Parkinson's individual might have a masked face, or it could be because of depressed affect. So you can see how it could be very confusing, which proposes, certainly major diagnostic dilemmas. So what do we do? Well, here's an easy schematic that some may find helpful. Again, consider that depression is a mood disorder and can include feelings of sadness, worthlessness, hopelessness, helplessness. Suicidal ideation is a strong clue that this is depression. So when patients are expressing these types of symptoms, this is really depression. At the other end is apathy. And here, there's a loss of get up and go, decreased interest in learning new things, emotional indifference, and so on. There's an overall blunting of experience and reduced ability to act and initiate things. And then there's some overlapping symptoms in the middle. There's anhedonia, lack of pleasure, slowness, and so on. So what helps me clinically is when I start hearing about these mood symptoms and dysphoria and so on, these are not characteristic of apathy. For me, it puts someone in the depression category. And I think that's something, this is really a major take-home message that everyone should, certainly, be mindful of. Now, why is it important to distinguish between apathy and depression? Well, why is it such a big deal? Well, this really comes down to treatment, particularly pharmacologic approaches. So a common treatment for depression are SSRIs. These are medications like Celexa, Lexapro, Zoloft, Prozac. In fact, these SSRIs are the most commonly prescribed antidepressants in the U.S. today, and they act by increasing levels of serotonin that are available in the brain, and they do this by reabsorbing serotonin or blocking the reabsorption. Well, it turns out that SSRIs might actually worsen apathy in individuals with Parkinson's. And this was the basis of a study that we did a few years ago when we found that the use of SSRIs was associated with increased apathy. And we thought this was possibly due to disruptive serotonergic modulation of midbrain dopamine systems. On the other hand, we found that patients who were on dopamine agonists had less apathy symptoms, as did patients who were taking selegiline or rasagiline. So this really highlights why it's important to make this distinction, because you certainly don't want to be taking a medication that potentially has the possibility of making apathy worse if you don't have depression. Okay, so let's summarize a little bit. What do we know about apathy? So over the past decade, before I mention this, I'm going to show you some follow-up slides about some of the things that I'm mentioning here. But in brief, we believe that apathy is largely due to a dopamine deficiency. It's associated with physiologic blunting, worsening motor symptoms, and worsening cognitive status. So as motor symptoms get worse, it seems that apathy may get worse. As cognitive symptoms changes occur, apathy can get worse. And it's also associated just with getting older. In fact, I have a group of what I call super-agers who are older adults who don't have Parkinson's disease. They're really, really healthy. They're in their 80s and 90s. They're living out in the community. They're doing great. But about 20% of them meet criteria for apathy, and it seems to be an age-related phenomenon as well. So that's another contributing part. So what underlies apathy? What causes it brain-wise? Well, as I mentioned, it seems to be primarily related in part to dopamine depletion in the brain's motivational circuitry. So there's evidence in support of this from many fronts. Apathy worsens if patients are taken off their dopamine medications, particularly, or if their dopamine medications are reduced, particularly dopamine agonists. Following DBS, oftentimes apathy can worse because some of the dopamine medications are reduced. But if patients are maintained on a high level of dopamine agonists, then this seems to help. And then there are a bunch of neuroimaging studies which have pointed to this. So dopamine seems to be a key player in this. Now this next slide and the one that follows it just highlights that apathy worsens with disease severity. So this slide just shows that with as the Hoehn-Yahr, which is a staging system for Parkinson's disease motor symptoms, that as the Hoehn-Yahr stage gets worse or more advanced, then apathy scores apathy scale scores get worse. The little yellow light is a cutoff for a diagnosis or for what we consider clinical apathy using the apathy scale score. So you can see it gets worse. And then the following slide is similar, and what this shows is that this is the same group of people that are followed over a short 18-month period, and it shows that apathy is worsening in line with motor scores on the United Parkinson's Disease Rating Scale. So apathy is increasing sort of in parallel with the motor scores, as the motor scores are increasing over a short period of only 18 months, whereas depression seems to be holding steady. It's not really increasing that much. So this next slide shows the relationship between apathy, the relationship to cognitive status, and so this also in both apathy and also in individuals with depression. And what's shown is that the teal bars are individuals who are cognitively normal. These are all Parkinson's patients. The fuchsia bars are individuals who have a diagnosis of dementia, whereas the yellow bars are individuals we don't know. They were just evaluated and we don't know what their cognitive status was. But what's clear is that for both apathy and for depression, there's a relationship between dementia. So as your cognitive status is worse, then there's increased apathy. One major question over the years is what type of cognitive difficulties are associated with apathy, and there's a long history showing that it's mostly related to problems in what we call executive function, things like planning, set shifting, and multitasking. Many, many people have shown this, and this slide just merely shows a study that was done by one of my graduate students that found that one particular executive function task was particularly related to apathy, and this is the Stroop. Now, I'm going to skip over the next two slides and also mention that a variety of studies have focused on how individuals with Parkinson's disease respond to emotional pictures, like the one shown on this slide. So in my lab, we have shown all sorts of emotional pictures to our patients, and we find that individuals with Parkinson's disease rate these pictures in just the same way as someone who doesn't have Parkinson's disease. So this snake would be rated as pretty horrific or aversive and unpleasant and arousing, whereas the children would be rated, who are coming down the slide, would be rated as, pretty positive and highly arousing. And our patients rate this just the way normal individuals do. But their body responds differently. So we find that their body doesn't respond in the same way. Their EEG signals are blunted in terms of electrophysiology, ERPs. We find their skin conductance and other physiologic measures are blunted, but this is only seen in individuals with apathy. Parkinson's disease individuals who don't have apathy look completely normal. So there's some emotional blunting that we see. So, to recap, apathy is common in Parkinson's disease, distinct from depression. It occurs in both demented and non-demented individuals. The best cognitive predictors of apathy are frontal lobe tasks, executive tasks, and it's associated with blunting. It's related to disease severity and age, and we believe apathy is an intrinsic part of Parkinson's disease, probably even more so than depression. So, what do we not know? Well, we think but are not sure that maybe apathy is a signature of disease progression, but one of the major problems is how do we best treat apathy? That's one of the things we least know. What are the best approaches for bolstering motivation and drive? Is this done best with medications? If so, which ones? Is it best done with other approaches? It's only during the past 3 to 5 years that scientists have really begun to tackle this difficult problem. Why has it taken so long? Well, for many years, apathy was thought to be the same as depression, so that was a real impediment. I remember a while back I applied for a grant. It must have been about 6 or 7 years ago. It was a local in-house grant, and I wanted to study a treatment program for apathy, and I got the review back in-house saying that apathy wasn't a problem. It would be a waste of my time to study this in Parkinson's disease. I was just appalled. Now, A few months ago, there was a wonderful little study that came out in the journal Neuron. It was called How to Turn on this wasn't the name of the study, but really the focus was how to turn on the part of your brain that controls motivation. And normal people were placed inside an MRI scanner, and they were told to try to increase an area of the brain, the ventral tegmental area that's important for motivation. And they were given in vivo feedback to try to increase this area of the brain. And in fact, they were able to do it. They couldn't think pleasant thoughts, but they had to think about things that they wanted to do and try really hard to get the system going. They found it to be really effortful and very exhausting to be motivated over these little short periods of time. But the important part of the study, it shows that we do have control over our brain systems by changing how we think. So, I want to just say there's no silver bullet for treating apathy, but the two major approaches that have been taken are pharmacologic and non-pharmacologic, and we'll talk about what we know thus far about these. In terms of pharmacologic treatments, there are really relatively few what we call randomized clinical trials for treatment of apathy, where apathy has been the primary target. But there are many studies that have been done that include apathy as a secondary measure. But in general, it appears that various dopamine agonists are associated with improvements in apathy. Also methylphenidate in small pilot studies. There was a recent randomized clinical trial which really did target apathy, and it compared two different dopamine agonists. They compared Mirapex and Requip, or pramipexole or ropinirole. And what they found was that Mirapex was far superior in this randomized clinical trial than was Requip. So another interesting, so that's important. This was the first study to compare two different dopamine agonists. And another interesting randomized clinical trial that was recently completed a couple of years ago used ribostigmine, or the Exelon patch. And this is often used in patients who are demented to improve cognition. It's a cholinergic medication. Well, this was used in patients with Parkinson's disease who were not demented, but were apathetic, and the results were interestingly very positive for improving apathy. So this implies that another medication other than dopamine might be helpful. Now, one of the issues with giving dopamine as a treatment, there comes a point where you can't give too much because it causes hallucinations and other types of side effects. So you can't always use dopamine as a treatment for apathy because of these other side effects. And that's led people to look at other ways to improve apathy. This was a study that was done at the University of Florida several years ago, directed by Hubert Fernandez when he was here, and the idea was to use repetitive transcranial magnetic stimulation over the frontal lobe. So what's TMS, or transcranial magnetic? It's a type of brain stimulation that involves magnetic pulses that end up stimulating the underlying brain circuits. And the overall goal was to learn whether this could improve apathy. The treatment involved coming into our clinic 3 times a week over the course of 2 weeks to receive this protocol. And these were all individuals who were highly apathetic. They were randomized to receive real transcranial magnetic stimulation or sham. And for the sham treatments, everything was the same. The people came in, they got the treatments. The only thing that was different was when it came to be stimulated, the coil wasn't turned on, so they didn't get real stimulation. So I thought the results were terrific. And what we found was that apathy improved with this approach. In fact, there was a dramatic improvement with this approach. But it didn't make a difference whether one got real TMS or the sham. So what could happen? Why could this occur? Well, there are at least 2 reasons why this study resulted in an improvement in apathy. One is behavioral activation, and the other is placebo. In terms of behavioral activation, these patients were doing something new. They were coming into our center regularly 3 times a week. In fact, many had moved to Gainesville for 2 weeks just for this study. They were behaviorally activated. They were doing new things. So this study had a large element of behavioral activation. What about placebo? Placebo could have also played a role. a role. Placebo's the belief that things are going to change. You believe that there's going to be an effect, that you're going to improve or get better. We see high placebo effects whenever new gadgetry is used, like this TMS machine, or when a study is taking place at a health science center. So that those are prime reasons why placebo tends to be, or in that situation, placebo effects tend to be high. So in any case, this improvement of apathy could occur because of behavioral activation to placebo or because of behavioral activation. Now, my colleagues weren't happy about this, but actually I was pretty pleased with the results. It implied that there were certain things that could be done to improve apathy. And so this moves into to behavioral approaches for improving apathy. Again, there haven't been many randomized clinical trials, but there have been a lot of behavioral studies that have looked at apathy secondarily. Dance therapy, music therapy, exercise, and even cognitive training. In all of these studies, scores in apathies improve, or they tend to be improved, but none of these are really targeting apathy per se. But what's critical in these studies is that people are moving and people are doing something. Now, there's one study I wanted to talk about, which is really targeted for treatment of apathy. It's currently in press, and it tackled apathy head-on. This was a dissertation that was done by London Butterfield. She developed a behavioral activation and goal-setting program specifically for Parkinson's patients, and she did a bunch of focus groups to try to figure out what might be most effective. It was a 6-week program that was largely done via the telephone, so that people didn't have to come into the center. And the key elements of this program is that a patient had to identify specific goals they wanted to achieve during an initial in-person session that lasted several hours. These goals that they wanted, or changes they wanted to make, could be across a lot of different domains. Could range from relationships to physical, emotional health, spirituality, education. So things like meeting and having lunch with a friend weekly, or attending a religious service once a week, or doing exercise 3 times a week. It was really up to the patient or participant to figure out what goals they wanted to meet. And they had to come up with 5 goals. Then they had to specifically develop specific plans and schedules for meeting these goals. They had a weekly telehealth session with a program coach, and they also had reminders to remind them to meet these goals. And the study was, I should mention, this is not a randomized controlled trial. This was a single-arm, unblinded study. That is, everybody was getting the treatment, and everybody knew they were getting the treatment. So this means it's not randomized. And this is often the type of trial that one does initially when one's trying to learn whether something might become potentially effective. So the goal was just to see if this was something that might be feasible and acceptable, and would this approach improve apathy. And what London found was that it was feasible. Only 12% of the people dropped out. People seemed to like it. She had good satisfaction ratings, and apathy significantly improved. So did quality of life. But there were no changes in caregiver stress or burden. So, getting motivated. What are some of the best practices that we need to consider if you yourself are trying to get motivated? So you can turn to business. There's a rich literature in the motivational domain. What are some of the best practices? There's actually a lot known about this. And the cornerstone for motivation is goal setting. And when you set a goal, if you really want to make change, the goals have to be specific. So if I want to exercise, my goal can't be improving my exercise. It has to be something specific, like I'm going to walk 3 times a week for an hour at a time. The goal has to be attainable. It can't be something unrealistic. If I said I was going to walk 30 miles a day, that would be totally unrealistic. But it can't be too easy. If I say I'm going to walk 100 yards, for me, that would be too easy, and I wouldn't get a lot of satisfaction and sense of efficacy. It's better if an individual sets their own goals. That's because there's a commitment to that. And also getting positive feedback or reward for meeting the goal. So the next element is implementation. And what we mean by that, what are the specific plans? When is this goal going to be done? When am I going to walk? What time? Where is it going to happen? So being very detailed about the goals. And then it's important to prepare for potential setbacks. So what happens if it should rain? What am I going to do? So you need to prepare for instances in which your goal might potentially be interfered with. And then it's also important to have external cues or reminders. So these are best practices. Then another way to conceptualize this, and this is from London's dissertation, is to be smart in selecting your goals. Your goals need to be specific, measurable, attainable, realistic, and timely. And the key thing is, you see in this little cartoon, is you don't have to go fast, you just have to go. Now, what are some other tips? Well, sometimes in our clinic, I have patients who probably it would be very difficult for them to sort of decide on particular goals. So we've created a UF Brain Activity Guide, which has different categories of activities. So within each category, for outings, crafts, and hobbies, we've listed 15 or 20 different activities that people could participate. It's like a smorgasbord. And so we work with people in trying to develop activities which maybe they haven't even thought about, which might be useful and helpful for them. And this activity guide we will be happy to make this available for you. It was actually created by one of my graduate students. And then closing up, I want to give you the bottom line of today. Apathy is a motivational disorder. Depression is a mood disorder. A tip is that when you see sadness, guilt, hopelessness, that all points to depression, not apathy. On the other hand, when you see a loss of get up and go, decreased initiation, think about apathy. Apathy worsens as Parkinson's disease progresses. It's associated with dopamine depletion. It can affect daily activities and it can be very distressful for caregivers. Treatment approaches for apathy are both pharmacologic and behavioral. You want to make sure it's important to make sure a patient's on an optimal dose of their dopa medications, particularly dopamine agonists, if they can take them. I would avoid SSRIs if possible. It's really, really important to keep movement. Use some variant of the behavioral activation and goal setting if possible. Even if a patient can't do their own goal setting, keep active. There's a lot of variability in individuals, but what is not variable is that we all have to keep moving. I want to thank you. I'm happy to take questions. I also want to thank my funding sources from the National Institutes of Health, the Michael J. Fox Foundation, and the state of Florida and others. And I want to also thank the staff of the Parkinson's Disease Foundation. Again, I thank you so much, and I really appreciate your attentiveness and time.
That's terrific. Thank you so much. A wonderful talk. And those of us at PDF in New York monitoring this find ourselves taking lots of notes and learning a lot ourselves. So this is the great benefit of this to us. We're not just doing it for other people. We're learning ourselves as we go along. And this has been no exception to that. Thank you so much, Fred. We've had a number of questions came in. You still have time to give us more. If we don't get through all of them, then you'll allow us to inform you later. But let's just start. Here's one of the earliest ones we got on when the talk was going on from the state of Illinois. And this questioner wants to know whether there's any sort of diurnal effect here. Does apathy fluctuate during the day? And secondly, separate point, does it tend to increase for those who experience it during off periods in Parkinson's?
Well, the first question is a great question. I don't know the answer to that. And actually, I do not know. That would be a great, someone needs to look at that. I don't know. We typically think of apathy as being more incremental over time, but I don't know if it's diurnally related, but that's possible. What was the second question? On-off?
Does it increase during off periods?
Some of my patients do talk about it increasing during off periods, but more typically they talk about depression as opposed to apathy. But I do have some that talk about it being more prevalent during off periods.
Thank you.
Yeah, I want to mention, honestly, there's not an awful lot of, there's a lot of research, but some of the questions that might be asked will be ones that we really don't know the answers to from a research perspective, but we might have cues from working with patients clinically.
Well, we found in our series, we're in our 7th year, as you know, and some of those interesting sessions have been those in which the very, very expert people, like yourself, will remind us that we don't know everything. So don't worry for a minute about this. We're very used to that, Doctor.
Okay.
Here's a question about, you talked about apathy and age to some degree. I don't remember whether you covered this question, which is, does apathy, for those who experience it, tend to increase with the progression of Parkinson's itself?
Yes, in fact, it does, even over very short periods, it can increase, and that really it gets worse. And one of the issues that is it gets worse as the dopaminergic disorder worsens. So we can't improve it by giving more dopamine at some point in time because that can cause hallucinations and things like that. But in general, it's thought to totally mirror the worsening of motor symptoms over time. So what that means is that people really, really if you have this, you really, really need to try to stay as active as possible, even if you don't feel like you want to. And that's a really tough call. If you're feeling sort of apathetic and not wanting to do things, it's really hard to get yourself motivated to do them. And so sometimes you have to enlist the help of others to help structure that. I remember meeting with a wonderful man up in the Panhandle, and his wife had sort of badgered him into joining it was a group of individuals with Parkinson's disease. They had it was a choral group, and so she made him join it. He hated it initially, but he actually enjoyed the camaraderie of it. And he found that, he wouldn't want to go meet with the guys that he hung out with, but they would call him and they would prompt him and cue him. So he actually needed the prompts and cues from the other members of his group, which helped him. But once he got there, he loved it and he enjoyed it. So he then began to recognize that if he didn't go, the guys in this choral group were going to call and badger him. But anyway, this is an example of sometimes if you have an apathy, you don't want to do anything and you need some prompts and cues. Now, another problem is sometimes the caretaker feels that has to push her apathetic person or spouse with Parkinson's disease, and that can be really tough because that can really pose some difficulties in the relationship. People start feeling resentful. So it's really it's a tough situation.
Actually, this relates to another question we had from somebody in our staff here at PDF, which has to do with whether the care partner relationship with somebody with Parkinson's who experienced apathy, is there any pattern that you've noticed that care partners can be themselves have depression or apathy increasing when their person with Parkinson's also experiences that? Is there something that you've noticed in this direction, or
absolutely. There's just increasing distress by the not so much apathy by the spouses or caretakers, but just increasing frustration and increasing distress and depression. Because there's been a change in the relationship, so that's a real problem in terms of the relationships between the caretaker and the patient. It's really tough. It's a tough situation. It's almost like you want to prepare people right at the beginning, right when they get when you get a diagnosis, that this is something that may happen. These are things that you need to start doing. Get things in place right away. I find that the patients that I've seen that have been least apathetic, even over the long haul, have been individuals who start off pretty active and they maintain high activity levels at the very beginning. And I noticed this initially, very early on, that we had some folks who were dancers, there was one woman who wasn't a dancer. She was an instructor at a fitness center, and she did classes, and she was phenomenal. I think she had Parkinson's disease for many, many years, and for, I think, almost 15 years, and she was still going to the gym. She really had so little apathy. She was just almost an anomaly. And it always struck with me that maybe there's something different about people who are moving a lot to start off with.
Great answer. Thank you. I mentioned earlier that we have many people on the call who are health professionals, and some of those you can tell, of course, by the kind of question they ask. Health professionals tend to ask often definitional questions, and so since there are so many of them, I will indulge this person from the state of New York who would like you to help us understand, Dr. Bowers, of the three components of apathy, which this person suggests are cognitive, emotional, and behavioral. Are all three required to qualify for the definition of apathy, or will any two do?
Well, as I said, there aren't really formal diagnostic criteria. There was proposed diagnostic criteria that was put out by Lynchians and Starkstein and Lynchians, and they require problems across each of the three domains. But another individual, and I'm blocking on his name right now, he also put out proposed criteria. And with him and his criteria, you didn't need all three. You only needed two of the three. I know that when you give questionnaires, some of these questionnaires, you don't always see all domains represented. I would probably say that the most important domains are probably the cognitive, lack of curiosity and interest, and the behavioral and the behavioral. I would think those tend to be the most potent domains that are really critical.
Very helpful. Another question for a professional. This person identifies themselves as a social worker from the state of Florida, and she would like to know, it's a very frequent question we get on these calls, Dr. Bowers, how can this social worker and others like her get training to help assess apathy with such scales and standardized tests like the LARS one you mentioned? What are the best recommendations you can make for sources of training in understanding apathy better?
These are available. The LARS is available. It's free. The apathy scale is available. It's free. They're really simple to give, but in terms of, if she's in Florida, why doesn't she just come visit me?
Wonderful. Great suggestion.
Yeah, she can come up and visit us. And I would think for other individuals who aren't in Florida, you can read about them. They're online. They're in the public domain. You don't have to pay anything to give these tests. So it really just takes reading about them. But I'm very happy to take anyone who would like to come to visit me for a session here in Florida.
This would be great. Would you, this is something we often ask, but not always. Would you care to give us a contact number and email address that people could use? If you
Absolutely.
Please do it online right now.
Can I tell it to you?
Yes. Or you can tell it to me afterwards. Would you put it there?
Okay, yeah.
Tell it to me afterwards, and we will then disclose it to those who ask.
Yeah, on one of the slides, I talk about this behavioral activity guide, and I actually have my email on that, so people could look at that slide if they want to, or I can also just give it to you afterwards.
That'd be great. Thank you. So for those on the call who are interested in this, I'll take advantage of Dr. Bowers' offer. We'll get her contact, and then you can then be in touch with us at www.pdf.org, and we'll be happy to answer that. Here's a general question. We're back to the general population. I don't think you mentioned this. Are there differences in the prevalence of apathy between men and women?
Oh, that's a wonderful question. My impression is that it's worse in men than women, but I have no data to support that. And in fact, when we have looked at that in we have a large group of people that we follow here, I don't find differences. But my clinical impression is that it's worse in men, but I'm not sure why.
Men, of course, do have a higher level of Parkinson's incidence, don't they? So
that's very true. So, this is a thing where my impression doesn't go along with the data.
I see. Very good. We had a bundle of questions on things you can do about apathy, and you mentioned one of them. I think you mentioned the transcranial stimulation.
Right.
But there was a question about focused ultrasound from New Mexico. There's a question about using dopamine agonists as themselves a medicinal approach to apathy. And there's a question about cannabis, otherwise known as marijuana, from the state of California. No connection. We don't suggest that California has more questions like that, but that's where this one came from. So in any order you wish, focused ultrasound, dopamine agonist, which as a medicine for Parkinson's, it also has obviously implications in this area, and cannabis.
Okay, cannabis, I have no idea. In fact, I would think it would do just the opposite, frankly, in terms of motivation. But for the dopamine agonist, the answer is absolutely yes. In fact, one of the few controlled trials actually showed improvements with apathy using dopamine agonists, particularly Mirapex. Now, Mirapex has other problems. But in any case, the dopamine agonist would be a medication of choice for treating apathy if a patient can take it.
And focused ultrasound?
I know nothing about focused ultrasound, so I can't even begin to answer that one.
Maybe we can scurry around after the session and get, we've got people here who know the technique quite well. And for that person, we know who she is, I think, from the state of New Mexico. We'd be happy to answer that. But thank you. We'll do that later. This last one, I think we have to be closing pretty soon. And this is the genre of even if you don't have something, can you imagine getting it? And this person from the state of New York would like to know if a person with Parkinson's has had no problems or challenges with apathy, is there something they might do to prevent this, delay it, reduce it in the future? Are there things you can do prophylactically to avoid getting this particular symptom of Parkinson's?
I would recommend, the major thing I'd recommend is remaining at a high level of activity, making sure you're busy, making sure you're engaged. You need to, if you're not already, and start doing that right now. I mean, occasionally, apathy just isn't seen in all individuals, but it's in a pretty high proportion. But if you're one of the fortunate few early on, and typically it's less apathy very early on, if you don't have any apathy at all, make sure you're staying busy, doing something, whether it's exercise or novel activities. Just be very, very busy to the extent possible. I mean, that's a major recommendation that I can make. Because
that's great. Wonderful
it's something
advice.
that you can do.
Wonderful advice. We have time for one more question. We've had a flurry of new ones in the last 5 minutes, so we will get back to you later on these. We know who you are. So forgive us if we don't cover it while Dr. Bowers is on the line. But this last question seemed to be general enough and interesting enough from the state of Oregon that we could ask it as a final question. It is, if there are people on the phone who would like to participate in studies, in the research that you and others have done to study this particular symptom of Parkinson's, are there places you can go? Does one begin with the University of Florida, with your good program, and see what you have, Dr. Bowers? Or is there anywhere else you would also recommend where there are studies that are still open, trials that are still open, that people might want to find out about?
I don't know who has open trials right now, but we can look on NIHtrials.gov. People are very welcome to contact me. We just finished a trial. It wasn't a trial. We were trying to learn whether individuals with Parkinson's disease could increase or upregulate their emotional reactivity. And we just finished that one, and we found that they can. The issue is, can you maintain that over a period of time? But they actually... The Parkinson's individuals did better than normal individuals, which was fantastic. So they're certainly able to do that. What we're getting ready to consider doing is a more randomized clinical trial similar to what Dr. Butterfield had done. I'm not aware of who has ongoing studies right now, but I can certainly look into that. There's several different ways that could be done. But I really appreciate people being willing to participate in research. It's so very important. I found over the years that the patients that we've seen have just been wonderful in terms of their willingness to participate in this way, more so than any other group of individuals I've ever worked with in my entire life. And I'm just so very, very appreciative of the contributions that patients have made to this.
That's a lovely, lovely attitude and a wonderful way to finish our talk. So thank you for that, and thank you for everything else you've done. If there were an applause function on our sound system here, you hear it from coast to coast and many other places. Actually, there was a call. We have some comments coming in one from the UK, where, of course, everybody's very nice. And this person said, very nice webinar, even though it's my first one. He's obviously going to come back for more. We have a person from California who said, just want to say this was an absolutely wonderful presentation. And from the state of Missouri, thank you, Dr. Bowers, for such an informative presentation. And there'll be many others like that coming in, which we may embarrass you with.
Oh, I'm embarrassed, but thank you.
The next few days. So thank you very much for that fine presentation, and thank you for all of you for coming. I do have one very important task, which our colleagues take very, very seriously, as I hope you know, which is the questionnaire, the review of the online survey. It should be on your screen. Please be sure, as I always say, we do use this as our central source of information on which we base planning for the future. I mean it seriously. Eli and our colleagues do a very serious analysis of this, so please fill out the survey, give us your feedback, help us improve our webinars to make sure that we give you the information you need in the hands and from the mouths of these terrific specialists who volunteer their time to lead these webinars for us. I also want to repeat my thanks and our thanks at PDF to AbbVie Incorporated and Lundbeck LLC for their contributions, tangible contributions that make this series possible. You've been involved, both the fine companies, for many years with this series, and we're always grateful for what that allows us to do. I want to remind you, for those old hands, but also the new hands, that an archive of today's event will be made available starting on Tuesday, next Tuesday, June 21st. It's available on our website at PDF, www.p as in Peter, D as in David, F as in Frank.org. Please make use of that as you wish. And, of course, as always, call us if you have questions or if you'd like to convey something back to Dr. Bowers from everything she's conveyed today. She sounds like a person who is extremely helpful, and I'm sure would be happy to help you answer any question that she hasn't answered in this terrific talk. So once again, thank you to Dr. Bowers for this great talk. Thank you for all of you for joining us and making this one of the record attendances of the year. I think we're over 700 actually accessing it. More? 705, and another 700 or 800 who signed up but have not yet taken advantage of this. They tend to come and use the archive, which of course is why we do the archive. So I hope you enjoyed it as much as we did at PDF. Thank you so much. And do we have any announcement for the next one? The next series will begin in Tuesday, September 13th, and it will begin with a talk by, I may mispronounce this, Sarah Regari and Rebecca Gilbert, Dr. Gilbert and Ms. Regari or Regare, and they will be talking on the subject of getting around transportation and travel with Parkinson's. As on Tuesday, September 13th, 2016. Stay tuned for this. You'll be receiving various information bulletins on this, and we look forward to having you at that next event. Thanks, everybody. Enjoy your summer. We're taking off this part of our business for the summer, but always be in touch with us if you have questions or comments. And once again, thanks to our terrific presenter, Dr. Bowers. You did us proud. Thanks. Bye-bye.